This is a very interesting X-ray we already discussed, and we can very easily see that there is pneumothorax. So pneumothorax can be very easily diagnosed. It's very simple to diagnose. We simply trace the lung margins from the rib area, and we should be able to see lung margins. So these white uh, lines, reticular lines, which are coming, these are almost coming up to this angle. So these are the bronchovascular markings which are coming up to the largest or lowermost and outermost portion of the lung. But in here, we can very easily see these markings, so we can very easily see which are there. This white reticular markings of bronchovascular markings. But in here, this is the angle, this is costophrenic, this is costo, that is rib margin, and phrenic, this diaphragm angle. And here we can very nicely see this is the lung margin. So lung collapse is there. So this is lung collapse is there. And here, outside the lung, we cannot see any bronchovascular markings in here. So, what are the indications of putting an intercostal drain? Because we know that this is all air which is accumulated outside the lungs. This will simply push the lung towards middle or in the center because air is accumulated here. So, what are the indications of putting an intercostal drain? So we know intercostal drain is put in between these ribs, in between the inter-rib distance, we have to put the intercostal drain. So as we can see in here, the lung collapse is very mild. In fact, it's very difficult to see this pneumothorax also. But when pneumothorax is significant, it simply causes collapse of the whole lung. So as soon as it start pushing the heart towards the opposite side, then the patient may have tachycardia. So as we know, if it is on the right side, it will push on the right atrium, and if it is on the left side, it will start pushing the left ventricular and left atrium as well. So, if it is causing significant respiratory distress, so if the patient is admitted with shortness of breath, if we do chest x-ray, if the patient has pneumothorax, and if the patient's respiratory rate is more, now usually up to 24 respiratory rate is very much comfortable. But if the respiratory rate keep on increasing over a period of 1 hour, 2 hour, 3 hour, or if the respiratory rate is very high, suppose if the respiratory rate is more than 40, more than 30, or more than 32, suppose at the time of admission the respiratory rate is around 16, 18, if it goes on 20, 22, 24, 26, 30. So if the respiratory rate is increasing over a period of minutes or hours, it means the patient's respiratory efforts are increasing. It means this pneumo is expanding and it is putting more and more effect on the lungs. So that is one of the indication for intercostal drainage putting. So it is respiratory distress. This is one of the most important indication. Second is the persistent and worsening tachycardia. So persistent and worsening tachycardia is one of the indication that the heart is getting compressed or heart is getting pushed by the enlarging air. So that will definitely affect the ventricular filling. So it can hamper the left ventricular filling or right atrial filling, and it can cause hypoxemia or hypotension. So cardiac pressure or cardiac burden where patient may show signs of tachycardia or patient may have hypotension. So when we in short we term it as a tension pneumothorax. Why we call it as tension pneumothorax? Because the air which is compressing the lung is that much high that it simply dampens or puts so much burden on this heart, either on the right side or on the left side, by pushing the heart or by directly pushing the left ventricle or left atrium or right atrium, so that the heart doesn't get filled into the diastole. So automatically the cardiac output is reduced or the stroke volume is reduced. So automatically the patient will have hypotension, and such patients may have arrhythmia, or such patients may collapse at any point of time. The other indication which is there is increasing pneumothorax, which is not getting settled with high flow oxygenation therapy. So even if the patient doesn't have respiratory distress or cardiac distress, but if the pneumothorax is increasing over a period of few hours or few days slowly, then that is one of the indication to put a intercostal drain. So or uh, the fourth thing is, if the things are not unclear, if the patient has multiple organ dysfunction, if the patient has, suppose, if some patient has road traffic accident, if the patient is comatose or intubated, and if the patient has then this pneumothorax, then at that particular time, it is very difficult to ascertain whether this pneumothorax is going to cause harm or not. So, in such patients, if the patient has tachycardia or hypotension, and in presence of road traffic accident or significant trauma with significant pneumothorax, especially if it is not getting reduced in size over a period of few hours or in a day or two, the ICD should be always put. So this was all about today, and thank you so much for today.